Thank you very much for the kind introduction. I'm certainly thrilled. This is the first time for me. I talk to and join our Pakistani colleagues. I'm really honored to be given the chance to share some of the a very humble experience on my understanding of how the methylation impacted the CNS tumor classification. But perhaps we cannot really start without just quickly passing over what's happening in Gaza nowadays. Our hearts really and prayers go for Gaza and the people of Gaza to those unusual circumstances. But we know that the road to liberation is usually very difficult, as we say in Arabic, it's surrounded and hedged by blood and by flesh and by souls. And this is what really our Gazan fellows are doing nowadays. The way to raise up the flag of Palestine again, the price has to be really in land, in homes, and in souls. So really, I know down from my heart that everybody, every single person listening to me right now from our Pakistani colleagues and otherwise have their prayers to our Gazan fellows. I have no conflict of interest to declare. This is the outline of my presentation. I'll be just touching quickly over the epidemiology of CNS tumors and then just quickly over the history of the WHO classification and grading of CNS tumors. And then just passing by quickly, I know that perhaps some of the audience will be the residents, fellows, and even medical students. Just touching quickly on the theory of DNA methylation and then going really into DNA methylation-based classification of central nervous system tumors and what has happened beyond the 2021 CNS5 classification. But importantly, perhaps a talk cannot be complete and cannot conclude without addressing the challenges to methylation-based classification of CNS tumors and then my humble suggested solutions. So into the epidemiology of central nervous system tumors. How frequent are central nervous system tumors? According to Lubukani 2020, central nervous system tumors account for the 18th most common cancer worldwide, with around 3% of all cancers globally. So it's not that common type of cancer. However, if we really go and look into cancer epidemiology in adolescents, in children, adolescents, and young adults, central nervous system tumors becomes the 7th. If we look into the age group 0 to 29, it becomes the 4th. And in the pediatric age group, it is the 2nd most common type of cancer. So central nervous system tumors become extremely important when we know that it really targets or hits this important age group of individuals, and that the most common tumor-related cause of death in young people is actually related to central nervous system tumors. Not only this, only 14% of patients would survive over 10 years. And those who survive over 10 years, unfortunately, will suffer a significant risk, disability, poor quality of life related to the diagnosis, to the location of the tumor, but also related to the effects of the treatment. And remember that the treatment is usually based on the histological diagnosis that is rendered by the pathologist. This is why rendering the appropriate histological diagnosis, assigning the appropriate grade becomes of paramount importance when it comes to central nervous system tumors. So how did the WHO classification and grading all started? Perhaps this is the very first classification in modern history that tried to classify central nervous system tumors. And what the authors at that time tried to do is to look into a resemblance between the tumor and normal counterpart, whether this is an adult brain or even in an embryonic brain tissue. And actually they succeeded because many of those, especially the yellow-colored tumor entities, survived the classification, survived with the same terminology until nowadays. Now, the first WHO classification of tumors worldwide came in 1957 for all types of tumors. And the aim was then to establish a classification and a grading of human tumors across different systems in the body, the breast, the GI, the lung, all types of tumors, allowing for epidemiological studies to be conducted, for clinical trials, to be globally beyond the institutions and national boundaries with the idea was to have regular updates and adding or deleting entities as appropriate. And in the tumor classification in the central nervous system in particular, we have to focus on the classification or the nomenclature and the grade of the tumor. For the classification, the basic was very, very simple. Trying to find a resemblance of the tumor to a normal counterpart. So what is the microscopic similarity between this tumor and an assumed cell of origin? And then the grade, and the grade is extremely important because the grade will determine the treatment that is applied or provided to the patient. And in a way, it was like a malignancy scale. And the grade, the idea of the grading when it started in the central nervous system was very, very innovative. So the grading of the central nervous system tumors is until to date is comprised of 4 grades, grade 1, 2, 3, and 4. But the way it started is that the idea was if you apply surgery and only surgery with no further treatment to a tumor, if the tumor was discrete and with really very low effect on the overall survival of the patient, on the mortality, but not the morbidity of the patient. If the patient survived the surgery and then lived for 10, 15 years, this tumor would be graded a grade 1. If the tumor was infiltrative, patient would survive, but definitely would recur or progress only with applying surgery. This is considered to be grade 2. Grade 3 tumors are those more pleomorphic, more aggressive tumors that will recur and will cause death of the patient in 3 to 5 years. And grade 4 tumors are those aggressive tumors that following surgery in a year or so, the patient will die if did not receive further chemotherapy and or radiotherapy. So the basic grading when it started really in the WHO was based on what if we apply only surgery, what will happen to the patient, how long would he or she would survive. And because of that, if you look, there is really, for example, if you look at grade 2 tumors, it spans something like low-grade fibrillary astrocytoma, the famous fibrillary astrocytoma in which there is no mitosis, no necrosis, no microvascular proliferation, to neurocytoma, for which the features on which grading is based completely different, to atypical meningioma, again, utilizing different set of criteria to establish the grade. So regardless of what are the criteria that fed into the grade, what really determined assigning a tumor initially into either one of the 4 grades was what would happen to the patient if they receive only surgery without further treatment. And according to this, the first edition of the WHO classification came out in 1979. It was mostly based on morphology. It grouped the tumors into glial versus non-glial, and glioblastoma was considered, as was the very initial classification of tumors, as embryonal tumor. The second edition came in 1993, and at that time, immunohistochemistry was really gaining popularity, and it really impacted at that time a grouping and the classification of central nervous tumors. And because GBMs at that time by immunohistochemistry mostly stained with GFAB, they were reclassified into astrocytic tumors. The third edition of the WHO classification came in 2000 and again was dependent mostly on immunohistochemistry with some molecular testing. The fourth was in 2007, more or less the same. So there were no major changes from 1993 until 2007. Now, in 2014, the group, a neuropathologist group met in Harlem, and what they did was very smart. They wanted really to integrate molecular diagnostics into a neuropathology. So they asked their hematologist and hematopathologist fellows to join the meeting. Their meeting, and they learned from them how to integrate molecular diagnostics into the classification of central nervous system tumors. And here came the 2016 revised fourth edition of the WHO classification, in which molecular diagnostics became integrated into the diagnosis and the classification of central nervous system tumors. So for the first time, we would see entities within the classification that are based only on the molecular signature of the tumor. So for diffuse astrocytoma, we have to say whether this is IDH mutant or wild type. For oligodendroglioma, the same. There appear for the first time entities, the diagnosis of which is only based on the molecular signature of the tumor. And for medulloblastoma, molecular subgrouping started to appear in the classification. Now that was in 2016, and at that time the recommendation was we have to start using what is known as the integrated layer diagnosis, for which we apply the histological diagnosis, the classification as we have learned over the years, as well as the grade. But then we should attempt also to add the molecular signature of the tumor and then come up with the final line of diagnosis that would integrate the three components: the histology, the grade, and the molecular signature for the tumor. Now, in 2018, the Heidelberg group came up with this amazing publication that was really the starting for the change of the landscape of CNS tumor classification based on methylation. And at that time, what they did, I will go into the details of the article because it's an important publication. They revised a large group of tumors and they built the classifier, that what is known as the German classifier. And the content or the classification bit it was so convincing and so in a way accurate that it made it into the fifth edition of the WHO classification in 2021. And as we know that for all the fifth editions of the WHO classifications, they've added what is known as essential and desirable criteria for all types of tumors, not only the central nervous system tumors. But what was peculiar about central nervous system tumor is that methylome profiling made it into the classification and into the diagnosis, so that more than 50% of the tumor entities within the fifth edition of the Blue Book required as essential or desirable criteria to perform methylation and methylome profiling in order to render the appropriate diagnosis for the case. So what is DNA-based, DNA methylation-based profiling in general? Now, for genetic makeup or genetic signatures of tumors, we have two theories. We have the mutation theory and we have the epigenetic theory. In the mutation theory, very simple, this is what we all know, that there is a structural alteration in the DNA itself through mutation, through insertions, deletions, that would give a signature to the tumor. In the central nervous system, the very famous one, P19Q in oligodendrogliomas, are typical examples. Now, in epigenetic theory, what happens is that the structure of the DNA remains as is, it's not affected. What happens is some modifications on top of the genetics that would affect the gene expression. So the gene itself, the structure of the gene is not affected. What is affected is the expression on or off expression of the gene based on this epigenetic change. And methylation is one example. It is the most common or most well-known example of epigenetic phenomenon. So what is DNA methylation? It is the addition of methyl group to cytosine, typically at CPG islands. So there is a specification for the addition of the methylation to cytosine. It's only whenever we have a C followed by G in either directions that the cytosine is prone to be methylated. So what happens if the cytosine becomes methylated? Or perhaps unmethylated with hypermethylation, the function of the entire gene will be suppressed. With hypomethylation, even silence genes can now talk and can be activated. So it's very simple. It's switching on or off the gene, depending whether the CPG islands are methylated or not. And remember that most CPG islands are actually present at gene promoters. This is why we almost always hear that methylation mostly affects gene promoter areas. And this is why it becomes extremely important. Is it only peculiar to cancers? Of course, it's not, because it can be part of normal biological processes, including embryogenesis, regulation of gene expression, imprinting, and so on and so forth. Tumorigenesis is only one aspect or one area in which DNA methylation can act. What is really peculiar about DNA methylation is that this signature is stable. It can be transmitted from one generation to the next, and it is stable during the course of the disease. And the signature or the printing of the original cell is not masked. So we have the printing of the original cell as well as the new signature caused by methylation that are stable and transmitted from one cell to the other, from one generation to the other. And this is the beauty and the strength of the DNA methylation. What about in central nervous system tumors? This is the paper that was first published by the Heidelberg group, Stefan Pitzer and the group. And a fascinating idea, I have to say. So what they did extensive training on more than 2,800 CNS previously diagnosed cases based on histological diagnosis. And these were classified using bioinformatics into 82 tumor classes and 9 non-tumor or control classes. And what they have chosen, 10,000 CPG areas or foci that were utilized in order to build what is known as the random forest model, in which the number of methylated versus unmethylated loci in each, for those, every single one of those 10,000 CPGs will be allocated for each and every single tumor, and then we'll come up with something that is known the beta value, in which the methylated loci divided on the methylated plus the unmethylated foci will render a score, what is known as like voting score, and accordingly the class of the tumor or the family of the tumor would be assigned. And the beauty of it is that the tool itself was made available for at the molecular neuropathology platform, for which you need to only register. And if you have the IDAT files for the tested cases, then you can easily apply to the platform, and the diagnosis of the case would come out for your submitted cases. So based on this idea, they were able, as I showed you, to provide what is known as calibrated score for 91 entities. and a cutoff that was utilized for the confident diagnosis based on the methylation was 0.9. So if a case shows a calibrated score of 0.9 or more, you're almost sure that this is the diagnosis based on the methylation. So the general rules that are used for the calibrated classification scores, as I told you, still the Heidelberg group uses the 0.9 score threshold to render a confident diagnosis, although nowadays other groups might suggest that a confident diagnosis can be made if a score of 0.84 is achieved in a tumor. If the tumor achieved a score of 0.3 or less than, this is not reported, and if it's less than 0.5, this is usually ignored. However, most cases, when you use the methylation profile, when you try to regularly, routinely use the methylation profiling for different types of tumors, most often the tumor will fall into a score between 0.3 and 0.9, يعني something in between those, the very well accepted and the discarded. Now, you have then to go back and look at the tumor quantity in your sample. If the tumor quantity is low, for example, this is the advancing edge or infiltrative zone of a low-grade diffuse glioma, and the calibrated score was 0.4, you can use this score like to support a confident diagnosis that this is a diffuse low-grade glioma. However, if the tumor content, for example, in a case of medulloblastoma, the score was 0.3, then you have to reject it because there isn't an issue in the tumor content itself. However, if the calibrated score was between 0.5 and 0.9, you have to try to utilize further different types of testing, for example, whole genome testing, sequencing, or whole exome sequencing in order to render the diagnosis. And this is the beautiful, T-SNE or the map for the 91 entities that were classes that were originally proposed by the Heidelberg group. And at their initial group validation, group diagnosis, almost 12%, 129 cases, were reassigned either a different diagnosis or even a different grade. Some cases were upgraded, for example, a diffuse astrocytoma. By morphology, a pathologist would call this diffuse astrocytoma grade 2, while actually in methylation profile, it turned out to be glioblastoma, equivalent to grade 4, while other cases, for example, an anaplastic ependymoma by methylation would be something like a glioneuronal tumor. So really, the methylation profiling was concordant, I have to say, perhaps in more than 85%, in more than around 80% of the cases. Around the 12% of the cases, there was some major changes either in the classification of the tumor or in the grading of the tumor that in a way would impact really the diagnosis. So based on this, if we just sum up the value of the methylation-based profiling of central nervous system tumors, remember that it always will point towards the cell of origin to the tumor, as well as the acquired DNA methylation change. And what really showed us is the huge biological complexity of the classification of central nervous system tumors. It definitely improved the diagnostic accuracy, and it started really to dismantle what biomorphology for a histopathologist, for a neuropathologist, would look like similar tumors, but their molecular signatures are different. So these are, in a way, different types of tumors. Now, what really happened is that I told you that in the original group, around 12% of CNS tumors had a difference in the classification or in the grading of the tumor. If we look only, and this is a recent publication from real-world data in pediatric brain tumors in particular, up to 35%, يعني around 1/3 of the cases received a difference in the classification or in the grading of the tumor. And we all know that pediatric central nervous tumors are quite complex and different from their adult counterpart. Because of that, if we have like a mixed data set, you will have that most reports will show the figure of 12% of change in the classification or the grade. But if your data set is really rich in pediatric cases, the difference of the tumor classification and grading might be as up as 1/3 of the cases. And of course, DNA-based methylation is easy to utilize, can be performed on both the formalin-fixed paraffin embedded tissue, which is routinely applied, and this is the routine testing that we use at our pathology labs, or it can be with almost equivalent proficiency with the frozen tumor samples. We need a relatively low DNA content, around 250 nanograms, and we can perform microdissections in order to increase the content of the tumor. And what they claim, I have to say, this was not our experience, that within a week you can get the results. It depends, sorry, it varies from one place to the other. With more experience, perhaps you need a week, but usually what is reported is around 3 weeks turnaround time. So if I give you just to go over a quick examples of DNA methylation profiling on the impact of DNA methylation profiling on CNS tumors, and we start with a glioblastoma. And in a glioblastoma, we know this is the single most common primary CNS tumor. It has an astrocytic origin, mostly occurring in adults, and the WHO grade is around grade 4. And we know that it can be either IDH mutant or IDH wild type, and this is associated with dismal outcome. Now, what happened with the methylation profiling is that methylation was able to segregate the glioblastoma into IDH wild type and IDH mutant type. So the IDH mutant tumors in general, they aggregated together, while the IDH wild type aggregated together. And what was really beautiful is that some cases based on morphology that would be assigned, I would call them based on morphology, grade 2 fibrillary astrocytoma turned out to be a glioblastoma even by methylation and profiling, and this came to be known as the molecular GBM. So by morphology, it's a grade 2 or a grade 3 astrocytoma, while by molecular profiling, this is considered to be molecular similar to GBM and was called molecular GBM. And actually, it made it into one of the essential criteria in IDH wild type gliomas, that even if I don't see microvascular proliferation or necrosis, if I find any of those signatures by methylation or other methodologies, then this is considered to be molecular GBM, and the patient should be treated as GBM. And the most common signatures here in the copy number variation was gain of chromosome 7 and loss of a chromosome 10. And as you can see here from the overall and progression-free survival, there is no difference in the outcome between molecular GBM and the high-grade GBM that is based on morphology. So it doesn't matter how I see it under the microscope. If I can show by methylation profiling with or without other ways to prove the presence of the molecular signature, then this can be termed, called molecular GBM, and the patient should receive a treatment as GBM. What is even more fascinating is the diffuse midline glioma, because many of those cases were grade 2 or 3, but they have this specific signature, and they actually, with methylation, they aggregated all the cases together, and now this came to be known as a special type of high-grade glioma that is diagnosed based on location as well as on molecular signature. So if I have a diffuse astrocytoma in one of the major midline structures in the thalamus, in the brainstem, in particular the pons, or in the spinal cord, that regardless of the morphology, mitosis or not, microvascular proliferation or not, necrosis or not, if I show this signature, the K27 a mutation or alteration, the patient is graded as a grade 4 and treated as a grade 4 glioma. Now, what really methylation also provided, and perhaps this is one of the strength areas in methylation, is in new families and tumor entities, in particular when it comes to pediatric type diffuse low-grade gliomas. So by morphology, I have to say that most pediatric type diffuse low-grade gliomas were classified and graded based on adult-based classification or diagnostic criteria. So I look for mitosis, I look for microvascular proliferation or necrosis. But apparently, these tumors aggregated together in a special group that were all assigned a grade 1 because they were associated with excellent outcome. And I have to say that without methylation or perhaps other molecular diagnostics, such a diagnosis cannot be rendered. What we can say nowadays in this tumor is because of the age of the patient and the morphology, pediatric type diffuse low-grade glioma or glioneuronal tumor. But in order to assign the appropriate group or tumor entity with the molecular signature that might sometimes dictate targetable mutation, we have to perform either methylation or other molecular diagnostics. By morphology, for pathologists, these almost all look like each other. So there is no way that by morphology, I, as a neuropathologist, will be able to differentiate between these subtypes. And this is one of the strength areas of methylation. The other very prominent contribution of methylation to central nervous system tumor classification was the group of CNS peanut tumor, primitive neuroectodermal. A tumor, it was like a wastebasket, and a tumor with a small cell morphology, supratentorial, infratentorial, that we're not able to assign into a group. We will call it peanut. Now, what happened with methylation is that more than 500 cases were assembled from different institutions and centers, and most cases were reclassified as other types of tumors. So those 500 peanut tumor cases were reclassified as choroidal plexus carcinomas, ependymomas, desmoplastic infantile gangliomas, high-grade gliomas. So they were all reclassified. But what really was fascinating about this project and paper, in particular, that 4 new entities came out of this classification that made it into the 2021 CNS tumor classification, into CNS 5 classification. Simply, those tumor entities cannot be diagnosed without molecular testing, in particular methylation profiling. For medulloblastoma, we know that medulloblastoma is the single most common malignant brain tumor in infants, with around 6 cases per 1 million child. And although the medulloblastoma is kind of considered a success story within the practice of a neuro-oncology, but we know that the quality of life of patients really, because of a treatment, is poor in general. And we know that initially the diagnosis was based on histology, and we have the classic histology, morphology, or desmoplastic nodular, or tumors with extensive nodularity, and what was considered to be a group of tumors associated with poor outcome, the large cell anaplastic variant. And then in the 2016 classification, there came the genetically defined subgroups of medulloblastoma with the Wnt activated, the SHH activated, whether this is TP53 wild type or a mutant, and then the group 3 and a group 4 tumors. Now, what happened with methylation, methylation was able to provide the 4 groups, as was other molecular testing like the nanostring classification, but methylation now has the capacity to further subclassify the classes or the groups of medulloblastoma. And this is becoming extremely important because there are many publications that are proposing a new risk stratification for medulloblastoma based on the molecular signature in addition to the morphology and the age of the patient and other parameters. So for example, with the SHH activated group, we have to differentiate between the standard risky group, the high risk group, or the very high risk group with the TP53 mutation, for which intensification of the treatment is warranted. What happened beyond the 2021? A beautiful study that looked at more than 2,000 cases prospectively classified according by methylation. And there was the good news, concordance with around 2/3 of cases between histology and methylation. But definitely there were some cases here and here and here and here that were not being able to be classified by methylation. And this is where the other new addition of methylation beyond the 2021 is becoming very clear, that new entities are being described more and more with the consortia, with the collection of large number of cases, with the new tumor signatures. And if you look into the literature, really every now and then, every couple of months, a new tumor entity is proposed based on methylation and the tumor signature associated with this methylation. So how should we really integrate methylation into our clinical diagnosis? There are lots of issues associated or lots of debate whether methylation should be performed on every single case, how to integrate with pathology. Would it really replace histopathological diagnosis? And the answer is no, it's not going to replace histopathological diagnosis, because what is proposed is to go parallel, perhaps in some of the tumor entities, not all tumor entities, with methylation. So we start with histopathological diagnosis with immunohistochemistry, and in some cases, especially unusual cases or difficult to classify cases, we would ask for methylation and profiling. And then if there is concordance in a way with pathological diagnosis, then the final diagnosis can be rendered. However, the final integrated diagnosis. Important issue to address: if there is discordance between methylation and pathological diagnosis, I have to say that the final say remains within the confines of the pathological diagnosis until a specific tumor entity is described, perhaps for which this tumor would belong, taking into consideration some of the limitations that I've mentioned for you before regarding methylation and profiling. So what are the challenges to DNA-based methylation classification of central nervous system tumors? There are definitely some challenges that should be addressed. Remember that with the classification, more and more entities are primary tumor, CNS tumor entities are being described, and it becomes extremely difficult for the neuropathologist, for the surgeon, for the oncologist to really follow up with all those new entities, especially that really an effective treatment is not yet described for most of those entities and sub-entities. The other issue with the classification is that most of the classifications that are present are based on selected populations, mostly from Western population, Western Europe and the Americas and Australia. So our area in general is very poorly represented. Now, remember even that if a tumor was had a signature or identifiable targeted mutation, it's very difficult to have access to treatment in our areas, perhaps through compassionate use, drug use, but this is also very difficult to maintain for a large number of patients. There is the issue of tissue stewardship. So with a limited biopsy, will the priority be for histopathological diagnosis or for methylation profiling? We don't have, of course, cannot forget about the turnaround time, because in practice, it takes around 3 weeks for the results to come out. And then the cost of testing, should we, as I mentioned, test all cases, selected cases, who will pay for the test when performed? And there are certain issues, challenges associated with methylation itself. In general, tumor cell content should be 70% or more. There is a margin of error in the diagnosis, for which histopathological diagnosis should always be the reference. Sometimes there are some misleading results, especially with the lower confidence scores or calibration scores. There is the issue of contamination of samples. So we know that with each run, there are 8 samples that are assigned to an array. And sometimes, especially with amplifications, for example, the MYC amplification or the EGFR amplification, contamination from the tumor with the amplification to other tumors has been described, and this is one major issue. And of course, we have to remember the limited access to methylation globally. So methylation can be tested in a number of centers, but definitely this is not available globally, which would widen the gap between the better resourced and the less resourced countries. These are my some of the suggested solutions. This is not my suggested solution, the NOS versus the NEC. And the WHO suggested that, okay, if you don't have the facility to test for a tumor to give the molecular signature, then you can say NOS, not otherwise specified. For example, I don't have IDH testing, so I can say this is diffuse glioma, NOS. The NEC is not elsewhere classified, is actually reserved to better resource countries in which utilizing different platforms and testing modalities, methylation, whole genome sequencing, exome sequencing, nanostring. Still, I cannot come up with a confident diagnosis. Then I can say that this is not elsewhere classified. Definitely, this does not, at least at the time being, does not perhaps apply to many countries globally. Unfortunately, many of our centers would still have to use the NOS descriptive diagnosis. Now, this is an initiative that I'm very proud to be a member of the steering committee, as well as leading the embryonal tumor group, the Oceanian group for neuropathology guidelines for adopting diagnostic approaches, the AOSNP adapter classification. And what we're trying to do is to describe surrogate markers that can help apply some of the classification as requested by the WHO into countries with limited resources. So, for example, in the medulloblastoma group, the group that I'm leading, we're describing some immunohistochemical markers that can be utilized in order to be able to suggest a subgroup of medulloblastoma, instead of just relying on histology and saying that this is, for example, classical medulloblastoma NOS. And the issue with, when we did a survey for many countries in the region, actually the DNA methylation profiling was not available in most centers in the Asia-Oceania region, as well as in the Middle East region when we asked for the testing. One other way, and we're proud to say that we, as well as Dr. Inam, members of the MNP Outreach Consortium, which should be starting very soon, in which a number of brain tumors, especially in children, adolescents, and young adults, will be tested through the consortium. So in conclusion, conclusion, I hope I was able to share with you the importance of DNA methylation profiling and how this resulted in major changes in the classification of central nervous system tumors that were incorporated into the 2021 CNS tumor classification, and how important is the molecular classification, especially in the era of actionable mutations. And it is DNA methylation is a procedure that can help to complement, to augment, to supplement, but not to replace histopathological diagnosis. But unfortunately, we have to acknowledge the access limitation to methylation and as well as to therapies, which remain major challenges to implement methylation in our part of the world. Thank you very much for listening.